First, I'll go over, it's not really too much of an anatomy time on this, but the sequence for hip extension / hyperextension should be gluteus maximus first, then proximal, the high hamstrings. The important thing to remember with the anatomy here is how medial those hamstrings attach. We looked at plenty of pictures showing how that comes all the way up onto the ischium, right? So these track medially, thus if I'm gonna palpate this, I can't be over there. All right, then it's gonna be, let's see if I can get that to, good. Then this is the only confusing part, is it's the opposite side lumbar erector spinae. This is where that cross bridge occurs of related to gait. The force is translating from this side of the pelvis and sacrum over into this lumbar area, which the easiest visual bridge to think about is how the glutes mesh into the lumbar dorsal fascia, and then if you follow the direction of that, how that meshes into the latissimus dorsi, which carries all the way up to the opposing shoulder. And thus, latissimus dorsi as an adductor extensor of the shoulder, extensor of the hip. So extensor, extensor, literally meeting together in this X pattern at the low back, right? So that's where you have to try to remember is what we're palpating is gonna be here, rather than trying to do all three together, just do 2 at a time and work your way up from there. So I usually am here, confirming glutes, hamstrings, or glutes, low back. All right, let me take that back. I'm almost always more concerned about whether or not the low back is firing first. There are plenty of people, and it's gonna be really common. I'll be quite surprised if anyone, including myself, is firing really good with gluteus maximus, truly being first here. All right, we're pretty predisposed to the proximal hamstrings being dominant in this pattern. And in many cases, that isn't really that big of an issue. I'm happy if I get these to co-contract. I think that's totally okay. What we don't want is the low back firing first, particularly relative to glutes. And you may not get a very big reversal if we think that maybe what a person starts with is a person starts to lift their leg into extension. And when they're lowered in gravity, this is more extreme, like going upstairs. Running ends up being a bigger thing, but functionally, standing up and particularly walking upstairs is where this is essential, okay? But if the low back is firing at 80% and the glutes are firing at 20%, that's bad, obviously, right? If we were to even get it to a 60-40, it might still feel to you, yeah, the low back's firing, but we have reduced that ratio so that the effort in general is better. So I'm just telling you, you're not gonna see magic happen too often. It's nice when it does, but it's not the most common thing. So it'll be this side glutes, this side low back, lumbar erector spinae, and then the person has to lift their leg where it actually clears the bolster. It has to be the whole leg because it has to happen at the hip, right? So they can't be bending the knee, they can't be doing some weird thing where their toes are still touching here. We'll work on all that. And they're just lifting their leg up like that. And then palpating here and seeing what that's doing. Now, how do we fix that? Here, not too bad. And this will be a little bit different for the people in the entry-level program, because this is where some of the rules begin to get broken, where I start you off with predominantly working towards the pelvis. The way we can get on these erector spinae structures, at least in prone more effectively, is to let yourself, you gotta build up your awareness of the anatomy better. But my preference is to do it like this. You have to kind of trust, it's not doing this, but I am here. I'm gonna be going a little bit downhill, so although my contact starts right here, I wanna be as close to that posterior superior iliac spine as possible. I want to be just medial to it. And this isn't quite SI, but boy, are we really close to it. We're like L5, S1, all of that. And now I have to trust that gravity's taking me this way. So my contact's gonna start here, and then I'm gonna kind of flatten out. And there's no way to do this. This is why you wanna limit most of your massage to being more here for like low back stuff. But here, I can't help but be a little bit twisted because I have to reach all the way to the midline in here. But this stroke, if when you're doing it, don't turn this into, don't do that. Just be here to there. And let it be really slow. If you're gonna make this count, you wanna hold this pressure for a long time. And then the rest of the massage part, let it happen everywhere else where you can be more comfortable, okay? I can be right here. What I do is I apply pressure there, and then I'll do this whole action, but then I'm feeling, I won't apply a lot of pressure. Then I'm feeling, I'm palpating lumbar rectus spinae, and then they lift, and I'm palpating here. And then I can easily transition that into, okay, sure enough, it's wrong. I apply more pressure and say, do that same movement again. And be sure to hold it. Sometimes, if there's a disc herniation or other factors here, where this action is particularly difficult, and it can be, that can be a fair amount of strain of lifting the whole leg. It can just be them activating their glutes isometrically. And people may not be able to find that, and your description of it is tough. It's like, is it a butt clench? It's like, you know, but trying to get that just to activate. I could just hold inhibitory pressure and tell a person to activate, and that's still having a conversation.
So they're tensing it.
Yeah.
Okay.
So just be, they're doing basically a clench.
Okay.
Ideally just a one-sided clench. The idea being, can you just try to, and that's hard to do.
Yeah.
It's hard to do. So.
Is everyone clenching? Just curious.
When we get to supine, I will show a better way to isolate getting gluteus maximus to fire. Because when we find clients that have true, and this is a thing, dormant butt syndrome, it's an actual labeled syndrome. Dormant butt syndrome, meaning their glutes don't have enough tone. It's like, if anybody that watches cartoons, it's Hank Hill. Everybody's a Hank Hill. How do we encourage this to engage better? This position isn't always the best, because if the person's low back symptoms are too bad for them to do this, then we need to figure something else out. And that'll be in supine, taking the leg off, and we can isolate this a little bit better. And so, like anything I'm saying, if a person can do this, then part of my assessment honestly tends to be confirming they actually can do that action without it causing distress. If them lifting that leg up is too strenuous or causes like any kind of bad pain, then we have to change what we're up to. Now, obviously assessing it, that'll be its own journey, but you want to start incorporating this because you got to build up just, you know, your confidence with it. Worst case scenario though is, you know, do the massage all in prone, finish the massage in prone, come back up and say, all right, one more thing for your low back. I go right over the sheet. And this was a routine I did with tons, if not all, of my low back people. I would come up over the sheet, get that good pressure, look for kind of the spot. We all know where that tends to hide in here, right? And then say, okay, lift that leg 3, maybe 4 times, go around, do it again on that side, 3 or 4 times. I'm gonna be repositioning them anyway. And then turn them on side, and then there we go. It doesn't disrupt my routine in prone. It ends up being one extra thing for the low back, and done. And worst case scenario, even if you have a hard time assessing it, it's still doing a good thing by encouraging that to be stronger and not dormant. Moving down, hamstrings versus gastrocnemius. This one's easier to palpate and find, harder to inhibit. Like here we can, if the hamstrings are really super over dominant, we could inhibit. body mechanics wise for anyone like prone, not using sidling as much, you can do crossbody stuff on those hamstrings and adductors. Soft fist works better for this, but I have used a palm sometimes. Soft fist I feel like does a better job, but I have gone crossbody and done work this way. And that ends up doing a lot of good stuff. As long as your reach and everything is sufficient. It's not gonna beat sideline, but it's an option. You can see I can get on those hamstring attachments really good. And then a person lifts their leg and I'm holding that down. That's how we would do that. But both of these will be interesting because we're gonna have a person moving the bone that we're actually pushing on. So that's gonna be an odd dynamic. Either I could hold here and just have them do the isometrics again, just contract and hold. That's having the same conversation of you less, you more. Over here, that's harder to do. But if a person just starts to do the action, so that's going to be part of the conversation, we'll assess with them, you know, they're bending at the knee. I can't have this one doing it, but yeah. See, I can build a whole human. But they're going to do, I have to tell them just this much, right? I'm not going to follow them the whole way. I just need enough, so the action just needs to be enough to start, like that. And then that's what I could do if I needed to hold pressure to correct and inhibit. And that's all this will be. We will not be inhibiting number one in the pattern. I know the video can't see it, but in the sequence of this, we won't be inhibiting number one. We'll be inhibiting number 2 or 3 while they do the active movement. And then since we're not inhibiting one is being told to strengthen, and whatever we're pushing on is being told to go down in tone. That's it. So here, for the correction piece, pretty easy to palpate. What we have to remember is that the hamstring split down here. So my hand placement has to be a bit more medial lateral, like this. If I go right behind the knee and I go central, I'm not gonna get the same palpation. So I have to just make sure I visualize that anatomy and come up and be a little bit on either side of those hamstrings. And you can usually feel those, right? You can find those. Just don't get caught in doing something like this, which I doubt anybody would do, but this hand like this, and this hand tends to be not like this. Can't be reaching around, no, I'm just feeling tibia. That's not gonna do it. Need to be back here. If not, right here. And then when they bend their knee, this one should be hamstrings activating first, then gastrocnemius. If it's gastrocnemius first, then it would turn into I'd be on the other side. Then I inhibit and have them do that same action. They're gonna be pushing the leg up into me. But I would just encourage, like I usually show them, I say, all right, this lift, start to lift, like, oh, right there. That's how much I'm gonna be asking you to do. Back down, inhibit, do the action. Now I'm telling this to turn off, but I'm not pushing on, it's being told to turn on. Easy peasy.
So are you basically fatiguing the muscle in?
With inhibitory pressure, basically yes.
Okay.
Inhibitory pressure, since we are squashing the muscle fibers, it makes it harder for them to do their shortening magic trick. So it exaggerates, making that muscle's ability to shorten, makes it more difficult. So it as opposed to fatigue, when we were correcting the gait stuff, that's true fatiguing. You just say, no. Right? Here, the inhibitory pressure is part of the signaling that we're creating and not allowing that muscle to not allowing those fibers to shorten and engage the way they normally would. So at least we're a resistance where when they try to, they're having to do a lot more, and then it will feel like they're pushing you up and out, right? When they're shortening, it's like you're being pushed out a little bit. That's why. But what then that does is, since this is having a harder time, the other stuff has to be told to pick up the slack and work harder. And I shouldn't be using this as an example because that's what we always want to be strengthening, right? So here, that's where we can be having that more nuanced conversation, is thinking, what am I also not pushing on? What I am pushing on is saying the signal to calm down and to reduce in tone. And what's the other piece? That's what turns this into a muscle firing pattern. idea or a muscle activation sequence. Idea, those are synonymous terms. Muscle activation sequences, muscle firing patterns get used interchangeably. But that's what takes it to that versus a muscle entry technique. Because all a muscle entry technique tends to be is inhibitory pressure plus active movement, right? So what makes it muscle firing patterns is me thinking further to what are the synergists or other things going on. Okay. Now, this is a quick summary, and then we'll go through kind of just, I'll demo on a person while everybody else is doing it. Because just seeing it like this and then trying to recreate it, it's always too much. All right. This is where these models work out. Well, now sideline. Way we would flip this is for the hip abduction one, okay? Usually the bolster is like on the anterior side of the body with the top leg, like the hip flex, knee flex, laying like that. We would swap that so that the bottom leg is flexed. Then this one's resting on that top bolster straight. Aligned in such a way where as far as this leg and their spine is concerned, it would look like they were standing on one leg. So I can kind of get this oriented correctly. About there. Actually, that's not too bad.
Yeah. Okay.
So, conversation for here, hip extension and hip abduction. It should be the glutes first, not the low back. If it's hip extension, it should be gluteus maximus, not opposite side low back. For hip abduction, we're talking same side stuff. So in many resources, they'll talk about this, about quadratus lumborum, which is that right there. But that's really deep underneath the obliques, as well as superficial fascia. So it's a deeper structure. What we're palpating here, and all the person has to do then is just lift this leg up enough where it's off the bolster. So what's nice is this isn't as much effort. But I'm palpating, find that greater trochanter just above it, and you're good. You have to be on it. Then low back-ish region, and they lift that leg and you feel what happens. And it should not be that low back kicking on first. It almost assuredly will be. Now, this is where applying inhibitory pressure plus having them just do that action, then that's our intervention. And that's my orientation. So there's the pelvis. Here. I tend to palpate, for example, like this. I do this. And then they do the action, and sure enough, they're wrong. I'm like, okay, back down. I sink in my pressure to the, now I'm trying to not just palpate. Now I want to sink in with enough pressure to tolerance. So I should maybe find the spot, kind of a thing. And then go, okay, again, the lift, hold. Ideally longer than 5 seconds. That's gonna be one thing too with any of this, if you're trying to change stuff, whether it be this or muscle energy techniques, longer than 5 seconds. But it should be closer to 10 seconds.
But they would hold their
They
leg
hold-
up,
they
or
hold-
that you would be
No, they
correct.
hold the contraction. They hold the contraction. I hold the compression throughout all of this. So I try to be just made of granite and hold the compression at as stable the depth of pressure as possible while they lift, hold, down, fully relax, lift, hold, 5 seconds, down, fully relax, lift, hold. That's where your body mechanics have to be, where you can just be there and hang out leaning with as little effort as possible, just so you can win the conversation. And some of using fatigue as an analogy, it really is a bit of a waiting game. That sustained pressure, if it's stable and consistent, the body will begin to realize, oh, it's not increasing in pressure, it's not like oscillating in some weird way, it's safe. Stable pressure will be construed as safe. So you're waiting for the body to interpret your pressure as safe. So it goes, oh, I don't have to protect this from you. And then that's where part of this conversation happens. Even with muscle energy, that's where it's really happening. We're pushing on something, waiting for it to finally accept the intervention as opposed to fighting against it and potentially reading it as a threat. All right. That one's not too bad. The only nuance here that I don't have written up there is in the event that their hip flexors or tensor fasciolata is particularly tight, what you might see happen while they try to abduct their hip is they'll flex a bit first. That they'll do a weird flex and then up. But they won't be able to just pick their leg up straight like this, or you'll notice that it's hard for them to even bring their leg back into like what looks like it's in correct alignment. But they'll just kind of kick forward first and what have you. Now, to supine. Make sure nothing's falling. Supine, not so bad. Let me orient it this way. There are aspects of this to be aware of relative to the medial, like the central, call it, quadriceps muscles. So here, in terms of the anterior upper leg, this is partly for my beginners. Sartorius, tensor fasciolata, creating that triangular shape, right? So let's remove that from the equation. Both of these are hip flexors. Okay? This one is an external hip rotator. This one is an internal hip rotator. They can get confused.
Yeah.
Sometimes they work together. Sometimes they're supposed to work independently. Well, not independently. There's always a synergist, right? Okay. So interesting point there. Okay. Rectus femoris, just a hip flexor relative to the hip. Okay. But it's the only quad that does hip and knee. Okay. But it is what would be a knee extensor. Guess what this one is? It's a knee flexor. So weird conversations, lots of conversation has to happen up here. That's why squashing it and having them do lots of movements to just say, everybody shut up, now recommunicate. Hit the reset button. And that's my honest go-to here is it's really complicated, squash it, have them do every movement you can think of. That's the big reset button. And it'll take you far. Okay, we get this out of the way. Now we're to the other three quads, rectus femoris, then we have the three vastuses. So there's vastus intermedialis. What can happen is these two do get stuck together. And that does cause issues. So that's something important to consider with this. But in terms of firing patterns, what we really need to be palpating and thinking of are these two. So vastus lateralis versus vastus medialis. And then just looking at their orientation is mostly what I want you, I already stated it earlier, but this one, how inferior it is and how much more superior this one, the bellies of them are. So my palpation can't be this. It can't be this. It has to be either this, or I really prefer for it to be this and this. I'm not usually going cross-body. The way it is oriented for me, / will be oriented for you, is more like this. And so palpate, I'm thinking like kind of the femur, more or less middle-ish, but this hand closer to the knee. So it tends to almost work out where my hand should be like this medial one here, this one's the lateral one. Now you're on the right stuff. And it should be this one first, then lateralis. Cool thing with this, really easy to incorporate in the session, because what we're gonna ask a person to do is not extend their knee where they look like this. We do not want their heel to come up off the ground like this. I want them to keep their heel down. I can't do it with this, but push the back of their knee down into the bolster. And this will mimic this action. I don't have him camera follow it too well. But instead of just me kicking out like this during walking, this mimics more the action of standing up out of a squat or a seated position where things are more loaded. So I want a person to know, push the back of your knee down to the bolster and flatten this out. That'll get these to kick on more, I promise. Well, when you feel it, it'll make more sense. But it's really easy to say, okay, I'm right here. This is how I do it. I palpate one with my forearm, the other one with my hand, and I'm already here. And I go, okay, kick that. I show them the action. I'll explain it. They do the action. I go, okay, good. This is doing a bad job. And most people it will. You'll have very, very few cases where you'll feel this really kick on strong. Then I just sink into comfort level, which probably will be not a lot of pressure. And then, okay, activate. And they kick on for a little bit. I hold that, and they relax, and I go, okay, and I maybe shift my position a little bit, and I'll work on this whole thing while having them do that contract, relax. But the signal that we're then getting out of that the whole time is reducing the tone of lateralis, also prying it off IT band, while the whole time encouraging medialis to be more dominant. And that one just became a standard. With the athletes and any of my knee-related population people, it just became part of the protocol. That once I was here, I would do kind of general warm-up stuff, like some kneading, all that, and I would go right into here, okay, activate. All right, here, activate. Here, activate. And it would, anybody with tight IT band stuff, anybody with that thing out here, the clients, it'll feel like you're getting something done. Really profound. Way less effort on your part and way less suffering on their part. So that's the firing pattern stuff. I will